All right. Hi, everyone. Welcome and thank you for joining us this evening. We have Amber Rodriguez here with us, and she will be speaking on breast surgery and reconstruction today. We do ask that if you have any questions that you drop them in the chat or in the Q&A, and we will ask Ms. Rodriguez at the end. You can go ahead and start.
All right, perfect. Well, hi everyone. Thank you for having me tonight. Um, I'll kind of be talking on, breast cancer surgery and reconstruction tonight. I've been doing breast surgery for about 6 years now. I don't much go in the OR and assist, but I'm definitely in the office seeing patients and patient education and coordinating and collaborating and all that entails. So let me go ahead and share my PowerPoint with you guys. Okay. And then if you don't mind, I've got this fun headset on just so that you guys can hear me, but I'm just going to stop my video just while I'm going through the presentation, and then I'll turn it back on when it comes down to the question and answer um, part of this at the end. Okay. Okay. So breast cancer surgery um, and reconstruction, just to start out. I want to kind of go through breast cancer risk in general. So, according to the American Cancer Society, with women who are considered average risk for breast cancer, we're seeing invasive breast cancer in the United States at around 13%, or that's 1 in 8 women being diagnosed with a new invasive breast cancer. Thankfully, the death rates from breast cancer have decreased by 44% since 1989. A lot of that, most of that is due to the improvement of treatment and early detection by, using those screening mammograms to detect new breast masses and abnormalities. Now, there are risk factors to breast cancer. There are some which are modifiable, and those are the risk factors that you can potentially change. So, those are factors like being overweight, drinking alcohol, smoking, being physically inactive or not exercising, and then using hormone therapy for menopause symptoms. There's also non-modifiable risk factors. So these are the things we can't change about ourselves. That would be a personal or family history of breast cancer, an inherited genetic mutation that we may have. Just getting older is a risk factor for being diagnosed with an invasive breast cancer. History of an atypical breast biopsy, dense breast tissue on mammogram, and then high dose radiation treatment to the chest before the age of 30, which is usually people who have a history of like Hodgkin's lymphoma. Now, when we're thinking of the breast, we do want to look at the anatomy, because then if we understand the anatomy, we'll kind of understand where some of our breast cancer forms. So those kind of oval shape um, structures, nice and pink up there, those are our lobules. So that's where a woman actually produces breast milk. And then that breast milk is transported by those milk ducts, which are those structures that you see coming off those lobules and moving towards the nipple. Okay. Those are two areas where we can actually develop breast cancer. Now, in order to diagnose and find breast cancer, I want to talk a second about breast imaging. So, screening mammograms, according to the American Society of Breast Surgeons, women who are average risk for breast cancer should initiate yearly screening mammograms by the start of age 40. Women who are around 25 should start undergoing a formal risk assessment for breast cancer. So, talking to primary or gynecology to determine when should I initiate screening, and that a lot of that has to do with, do you have any family history of breast cancer and those kind of risk factors that we were talking about earlier. And then women who are higher than average risk of breast cancer should undergo screening mammography, but should really be offered yearly supplemental imaging. So something in addition to mammography if we're higher risk, which could be ultrasounds or breast MRIs. So now screening mammograms, we do those to look for new masses, new abnormalities in our breasts for women that don't have any symptoms. Kind of in addition to that, for women who are having symptoms, then we move to a diagnostic mammogram. And what that does is that actually gives us more views of the abnormality that we're looking for and can zoom in, giving us more information. So some of the reasons why we would do a diagnostic mammogram instead of screening is one, if we do have an abnormal screening. So say something's picked up on screening mammogram, we would then call that patient back and ask them to come in now for a diagnostic mammogram, which can give us more views and magnifications. Something else we would do diagnostic mammogram for is a new palpable breast lump, nipple abnormalities, whether a rash or a wound, nipple discharge, breast swelling, skin redness or thickness, and breast pain. All of these can be reasons and symptoms that can come up that women may have that we need to do diagnostic imaging for. And then in addition to the diagnostic mammogram, we would also, this would be plus or minus an ultrasound depending on what's going on. We would also, we can also consider breast MRIs for certain indications, and we'll kind of go through some of those coming up. These are some actual images of how breast cancer can look in the different breast imaging modalities. So on the top, we've got a mammogram, and where it's circled in yellow, you see this kind of darker white abnormality that doesn't match the surrounding breast tissue. So that is one of the ways that we can find breast cancer on mammogram and how it would look. Lower right-hand corner, you've got an ultrasound. Um, and you can see that this mass over on the left-hand side, it kind of like juts out, and on the right-hand side, it's irregular. So we're looking for irregular borders and different characteristics on ultrasound that are more concerning and suspicious. And then lastly, on the bottom left-hand corner, you're going to have our MRI. And MRI is it uses contrast, and we're looking at blood flow in the breast, and that contrast can actually light up, or what we call enhance, on a breast MRI, showing that that area is kind of taking up that contrast, and there's more blood flow to that area, which can look suspicious, kind of like in this area. You can see that there's a specific area that's lighting up and taking up that contrast. Once we find something on breast imaging, then we have to figure out how to biopsy it. And there are different ways of biopsying these findings. So one of the first ways is an ultrasound guided biopsy. And so we utilize an ultrasound probe. We re-identify that breast mass, use a special needle, and which is guided by using that ultrasound probe, take a couple tissue samples from the mass, and then send that off to pathology to see what it looks like under the microscope. We can also do it by stereotactic guided biopsy. This is also what you would consider a mammogram guided biopsy. Most of the time, we have a table where there's a hole in it, and your breast kind of comes through that hole, and there's a mammogram underneath that table. Laying very still, they use the mammogram to find that abnormality. Special needle takes a couple tissue samples from that mass or that abnormality, and then it gets sent off to pathology. Another way we can biopsy is through our MRI guided way. So you would be in the MRI machine, and then underneath that table, there's again something similar to a mammogram where your breast is compressed. Using the MRI pictures, we would find that area, use a special needle, take a couple samples, and send it off. Very important thing I forgot to mention, your breast is numb. during these biopsies. So very important detail that I forgot. This is all done after you've already been numbed up. The breast has been numb. The last biopsy we can do is a surgical biopsy. So this is where we actually do surgery to remove the mass or the breast lesion, and then that sample sent off to pathology. Some of the reasons why we might do a surgical biopsy um, is that area may not be easily accessible with our biopsy needle. So perhaps it's too close to the skin or too close to the nipple where we could potentially injure some of these structures with the needle. So we can actually do a surgery to prevent additional injury. Um, Another reason we might do a surgical biopsy is if the needle biopsy was attempted, but the tissue results don't match what we're seeing on imaging. So sometimes we can see something that looks very suspicious on imaging, but when we get the pathology and it shows that there's nothing wrong and it's completely benign breast tissue, we may consider that what we call discordant, or it just doesn't match up in the bigger picture. So we perform a surgical biopsy to kind of confirm a diagnosis or really see what's going on. So now moving to the pathology report, when we actually get the tissue back, we want to know what's going on in that tissue after it's been looked at under the microscope. So in regards to kind of cancer, there are there is invasive breast cancer, but there's also non-invasive or in situ breast cancer, and we'll go through what that means a little more in the coming up slides. In the pathology report, we're looking at the grade of the cancer. So how do these cancer cells look when compared to normal cells in terms of their size, their shape, their rate of growth? Um, we're looking at our hormone receptor status. So in breast cancer, there's 3 tests that we run and look at to determine what kind of cancer are we looking at, because there are different types of breast cancer. So 2 of those tests are what we call our hormone receptors. So it's looking at an estrogen receptor and a progesterone receptor, and those can be either positive or negative. The last test we're running is we're looking for the HER2 protein on the breast cancer cell, and that can also be positive or negative. And again, we're going to kind of look at like, well, what does that mean in regards to treatment and so forth. So ductal carcinoma in situ, this is our non-invasive breast cancer. This is what we would consider a stage 0 breast cancer. It is the earliest stage. It is malignant, so it is cancerous, but it's not invasive, which gives it that stage 0 staging. Okay, so this does need to be removed surgically. It does need to be treated. If left in the breast, it can continue to grow, and eventually it can potentially change to an invasive component or grow an invasive component. As you can see in the picture, so the ductal carcinoma in situ, it's growing inside the milk duct. It's kind of contained within the milk duct. It hasn't broken through the wall of that duct, which is why it's non-invasive. Now, these are a couple of different invasive breast cancers. So we can, like I said, form breast cancer in our lobules, which would be, if you follow the lobular neoplasms down to invasive lobular carcinoma. And then moving to the right, these are our ductal neoplasms. So there's invasive ductal carcinomas of no special type, which is most of our new invasive breast cancers. About 70% will fall into that invasive ductal carcinoma of no special type. And then there's invasive ductal carcinoma of special type. And you can see, and I apologize, these aren't the easiest to read in this picture, but these are all different types of breast cancers that originate in the ducts, but are very much different from the no special type. And that accounts for about 10% is the invasive ductal carcinoma of special type. And then our lobular carcinomas are about 10 to 20%, which form there. Once we know it's an invasive breast cancer, we want to know again what type it is. And that's where those hormone receptors and that HER2, um, protein kind of comes into play and tells us how does that breast cancer behave? What are its characteristics and how is it best treated? So looking at the, kind of the subtypes, you've got a hormone positive, HER2 negative breast cancer. That is the most common type of breast cancer, about 73% of all of our cases. Um, and then you move down to the HER2 positive. And of course, we can have like a hormone positive plus HER2 positive, as you can see in that picture, which is about 10% of our cases. A hormone negative HER2 positive, which is our least common type of breast cancer that we see in about 5% of our cases. And then finally, we have our triple negative, which is about 13% of our cases. HER2 positive and triple negative breast cancers, they do tend to be more aggressive um, than our hormone positive breast cancers. And they're almost always treated with chemotherapy, either before or after surgery. Not all hormone positive breast cancers benefit from chemotherapy. It kind of depends on the stage of the breast cancer, which we'll talk about shortly. And the staging is basically how advanced is it? And then further testing on the tumor. We've got some newer testing that we can do on the breast cancer tumor after we've removed it from surgery, which will tell us kind of the aggressiveness of it and how beneficial um, chemotherapy would be to treat it. These are kind of the overview of the stages of invasive breast cancer. We already saw stage 0. That's not on this slide, but stage 1, early disease, the tumor is confined to the breast. One thing that we are always looking for when we find an invasive breast cancer is we do pay attention to the lymph nodes in that armpit on that side. Invasive breast cancer, the first place it usually wants to go is to the lymph nodes in the armpit. So we look and we will test to make sure that it hasn't made it there. So early disease for stage 1, it's not in the lymph nodes in the armpit. Stage 2 usually has a tumor greater than 2 centimeters in size. It can be smaller, but it also has reached the lymph nodes in the armpit. Stage 3, little more advanced. So the tumor can be up to 5 centimeters in size. The axillary lymph nodes on that side, the disease is a little more extensive. There's more lymph nodes that are involved than maybe just one or two. Like we can see in stage 2, the tumor can also be extending to the chest wall, or maybe even the skin can be involved. And then stage 4 is our advanced disease, where that breast cancer has spread beyond the breast and the lymph nodes and has moved to distant sites such as the bone, liver, lungs, and brain. After we get our biopsy results and we know what kind of breast cancer we're dealing with, we may order additional scans or tests such as a breast MRI if there hasn't been one done, maybe a PET scan if we know that the breast cancer has made it to the lymph nodes in the armpit, then we know there is potential, it could potentially spread elsewhere after it's made it there. So we may order a PET scan to look at other organs in the body to make sure that there's nothing that looks suspicious like the cancer has spread. May see a medical oncologist to discuss options prior to surgery. And then you may do genetic testing. And what genetic testing is it looks at the body's DNA to see if there's a mutation in our DNA which caused the cancer. There's certain mutations that we find that after following people over the years, we found that they're at higher risk for cancers. 90% of breast cancers are not associated with a genetic mutation. So, our new breast cancers that we're diagnosing, only about 10% of them are going to be related to a genetic mutation. So moving into like the breast surgery options, we do have the option to do a lumpectomy, which is also referred to as breast conserving surgery. Most of the time this is the preferred treatment because it's a smaller surgery, less recovery time, and ultimately we're allowed to leave the rest of the breast behind. We're just removing a part of it. It's usually appropriate for single area of cancer, smaller tumors. Other option we have for breast cancer is to do a mastectomy, which would be the removal of the entire breast, plus or minus the nipple, and we'll kind of get into those nuances shortly. The mastectomies may be appropriate when we're seeing multiple tumors in that breast, when we have a very large tumor that we don't think we'll be able to remove with just a lumpectomy. Sometimes the tumor is right under or involving the nipple, so we'd almost have to remove this central part of the breast. So ultimately, maybe a mastectomy would serve that woman better, and or patients with a genetic mutation. So if we know you have a genetic mutation and you have a predisposition to getting breast cancer, removing the entire breast may decrease the risk of getting another breast cancer in the future if you're already at that increased risk. Whenever we're doing surgery for a breast cancer, we have to make sure that we're sampling the lymph nodes in the armpit. We do look at them with imaging, say ultrasound and breast MRI, to see if there's any obvious disease or abnormalities that we can see in the lymph nodes. But ultimately, the best way to know whether the breast cancer has spread to the lymph nodes is by actually sampling them or removing them. So we can do a sentinel lymph node biopsy, which is removing the first 1 to 5 lymph nodes that drain the breast, and sending them to the pathologist to see if there's any cancer in them, versus an axillary lymph node dissection, which is actually removing, axillary levels 1 and 2. And I'll show you a picture of this to kind of um, help you understand it. But sometimes we have to do a lymph node dissection in people that have more disease in multiple lymph nodes in the armpit. So in order to do a sentinel lymph node biopsy, we have to find the first couple of lymph nodes that drain the breast. And the way that we do this is we actually inject a dye into the breast, and it will drain from the breast and into the lymph nodes. So when we make an incision in the armpit area, we can find these lymph nodes that have taken up this dye. Sometimes we use a radioactive dye, which is where we actually have a probe, like you see in the picture, that'll make a sound when we find a lymph node that took up that dye. And we do have a blue dye. So when we open up the axilla, we can find lymph nodes that have turned blue because they have, that dye has drained into them from the breast. Those are removed, and then we look at them under a microscope to see if there's any breast cancer. Axillary lymph node dissection. So in this picture on the right, the yellow lymph nodes that you see are what we consider level 1. They're in the lower axilla, usually the first areas that's draining the breast. And then there's a couple of green lymph nodes with that second arrow. And usually when we do an axillary dissection, we're removing most of the lymph nodes that are in levels 1 and levels 2 to try to remove the disease that has made it to the armpit, to try to get control of the breast cancer. We don't take doing an axillary lymph node dissection lightly because we do know that it has increased risk for lymphedema. And it's anywhere from 15 to 30% risk of someone getting lymphedema. There are different stages, as you can see in that lymphedema picture that I've posted. Stage 1, you're starting to see kind of an asymmetry between the two arms. One looks bigger, and then they kind of progress from there to the point where some people have issues functionally using their hand and using their arm. It's very heavy, and now we're at increased risk for infection in that arm because of all of that. So whenever we can avoid an axillary lymph node dissection, we definitely try to do that. Now, moving on to the actual surgery of the breast. So, lumpectomy, we're removing only the tumor. And then you will receive radiation therapy after a lumpectomy to decrease the recurrence. So when we leave the rest of the breast and only remove the tumor, we'll radiate that breast in order to decrease the risk of the cancer coming back. They're kind of a team. So what we found is that when we do a lumpectomy followed by radiation, the chance of that breast cancer coming back is almost equivalent to doing a mastectomy, which is why we've been able to move away from doing mastectomies for all women who have breast cancers like we used to do. And we can offer lumpectomies now with radiation as a safe and effective way of treating breast cancer. So now there's a couple different mastectomies. When we're looking at it. So there's a total simple mastectomy, and this is where we remove the entire breast and do a sentinel lymph node to make sure that the breast cancer hasn't made it there. And usually these are the women that are being closed flat. So we take a majority, we take the nipple, we take a majority of the skin, and then you have an incision across the center of where your breast was, and it's lying flat. There's a modified radical mastectomy, and this is when we have to do a mastectomy, but we have to do that axillary lymph node dissection in addition. So we're taking the level ones and the level one and level two lymph nodes because the breast cancer is more locally advanced, and we know that there's additional lymph nodes than just maybe one or two that may be involved and need to come out. We have a nipple sparing mastectomy. So this is when we're starting to move towards reconstruction options, and this will kind of lead into it. So what we're doing is we're leaving as much skin and sometimes the nipple behind when we're excising all the breast tissue underneath it. And then there's a pocket that we're leaving under there. And that pocket is used for our reconstruction. We can fill that pocket to reconstruct a breast once we've removed all the breast tissue. So here, there's a couple of different incisions where we can place the incisions, but ultimately the long and the short of it is we're excising all the breast tissue underneath, leaving as much skin and potentially the nipple if safe to make a reconstructed breast. So there are multiple options when it comes to breast reconstruction. And this is where the specialty of your plastic surgeon is going to come into play because some breast reconstructions are contraindicated depending on, patient comorbidities, size of your breasts, way your breasts lie. There's multiple factors that go into choosing the right breast reconstruction. So, having a plastic surgeon that you trust is important because they will really help guide you in what your goal is and what they think will benefit you the most. So one of the options is an implant-based breast reconstruction. Now, this is usually a two-step process. So usually in the first stage of your implant-based reconstruction, the breast surgeon will remove the breast or do the mastectomy. And then in the same surgery, the plastic surgeon will come behind and they'll put in what's called a tissue expander. It's kind of shown in the top picture where the tissue expander, it's a placeholder, it's temporary, and actually it is usually put in deflated to allow the breast, the incision, everything to start healing immediately after breast surgery without putting too much tension and stress on everything that we've done thus far. Now, what you'll see is there's a little needle and there's a syringe coming off of that needle. So the tissue expander actually has a port that is under the skin, and we can find that port and we, puncture the port and start injecting saline, which then in that next picture you can see that that tissue expander is starting to fill up and starting to take the form of more of like what you would think of as a breast. And that tissue expander can continue to be filled, usually a small amount at a time, because what we're doing is we're trying to stretch the skin out again in order to create that pocket and ultimately fill it with a final implant if you're doing the implant-based reconstruction. There's saline implants, there's silicone implants. I do know, with our plastic surgeon that we work with, he really likes the silicone implants. We've come a long way in regards to the silicone implants. They used to have kind of a stigma and people were kind of scared of them. Um, but again, we've really come a very long way, and silicone implants are showing to be a very safe option for our patients that want to do an implant-based breast reconstruction. Um, Now, moving to what we call the autologous breast reconstruction. And autologous is basically using your own tissue from somewhere and then filling that pocket that we made when we removed the breast tissue but left as much skin as we could, with your own tissue. A lot of times that's still a two-step process. So like in the first option where we use that tissue expander, a lot of times we'll do that as well for the autologous breast reconstruction. So at the time of the mastectomy, we put in that tissue expander, we start expanding it until it's the size, that the patient wants. And then we decide, well, what are we going to fill that with? And if someone wants to fill it with their own tissue, there's multiple places where that tissue can be taken from. I know here at Rush Copley, we do a lot of DIEP flaps, which is that first picture kind of in the bottom left-hand corner. Um, and these DIEP flaps, they're called DIEP flap because it actually takes an artery called the deep inferior epigastric, and that is clipped and taken up and put in that breast pocket. And then those vessels, those blood vessels are reconnected to vessels in the breast, which just help with blood flow and, just creating a very nice live breast reconstruction. So I know our plastic surgeon does a lot of those DIEP flaps for his autologous patients and autologous breast reconstructions. We also do latissimus dorsi flaps. Basically, we take skin, fat, muscle, and the blood vessels from right behind where our shoulder blade is, and we can actually kind of bring it around and put it in that pocket that we made when we did the mastectomy and did the tissue expander. And then lastly, another place we can take tissue, it's called a tram flat. So we're actually taking abdominal muscle along with skin and fat and moving it up into that breast pocket that we made at the time of surgery and with that tissue expander. And all of those are really, really nice options. If you really don't want an implant, and you want your own tissue moved into that space. They do have some different recovery times. So for a lumpectomy, recovery is usually like 1 to 2 weeks. You're sore, but you're getting back to normal pretty quickly. And then after, you've kind of recuperated from the lumpectomy, then you're seeing the radiation oncologist to kind of start discussing radiation and moving forward with that. A mastectomy, If you're just doing a mastectomy, no reconstruction, usually about 4 weeks. With mastectomies, you will have drains. So you will go home with a drain to take care of. And then, as you get further out from surgery, say about a week from surgery, that drainage has decreased over that week, then that can be removed. We put drains in because naturally our body's going to want to fill that pocket we made with the mastectomy with fluid. It's just our body's natural way of trying to heal that wound. The problem is if we let it fill up with fluid, it can put tension on the incision because it's almost like a water balloon and you just keep filling it and filling it. We're afraid that we may have issues with wound healing or the incision opening up. Definitely can be more painful if we're allowing, kind of that tension and that stretching of the skin immediately post-op. So those drains are important to allow time for that area to heal without stress. When we're doing, mastectomies with reconstruction, recovery is about 6 weeks. With the implant-based reconstruction. So, you still have the drains. And now you're going to start having your expander filled. Usually every 7 to 10 days, you're coming in and seeing one of the team to keep filling you until you're fully expanded. But usually people are feeling pretty good by 6 weeks. May not be completely expanded, but overall, feeling okay. When we do autologous reconstruction, that's definitely a longer recovery time up front. So usually, I mean, as far as our protocol for patients that are getting a mastectomy with implant or with that tissue expander, you're in the hospital for one night and then you go home the next day once you know how to take care of your drains. We make sure your pain's under control, not having any issues with bleeding. Um, at the second stage, so that's when people have that expander removed, and then there's an implant that's put in. That's an outpatient surgery. It's a much smaller surgery than the initial mastectomy and expander placement. So you come in, you get that done, you go home the same day. For autologous reconstruction, so second stage, but now you're going to have your own tissue moved into that pocket instead of an implant. You're usually in the hospital anywhere from 3 to 7 days, depending on how the recovery period has gone. If we kind of go back to the autologous reconstruction, as you can see, like we're not just doing surgery in the area of the breast. That tissue has to be taken from somewhere. So people have incisions in their abdomen or, behind their shoulder blade. And those are other surgical incisions and surgical areas that we have to monitor. And of course, there's, discomfort just from having surgery in that area. So you've got multiple areas that you have to monitor and watch. We do have to watch for blood supply when we're taking the tissue and moving it somewhere else. We watch that area in the breast very, very closely to make sure that that skin or that muscle doesn't start dying because it doesn't have the blood supply it needs. So very close monitoring, longer hospital stay in order to make sure that everything is going well. So that recuperation after surgery is a little longer. Usually feeling okay by 6 weeks once you've been discharged from the hospital, but I would add a couple more weeks. So maybe more like 8 to 10 weeks where you're kind of getting back to normal after that autologous breast reconstruction. Now, many times there's additional treatment after surgery. So, chemotherapy can be used to treat our breast cancers, um, usually required for HER2 positive or triple negative breast cancers. Um, there's specialized testing to determine the benefit of chemotherapy in the hormone positive breast cancers, like I had mentioned earlier. So basically, once we remove a hormone positive breast tumor, we can send it off for a test. And we use the Oncotype DX, which will give us a score of it'll give us a recurrence score, which is basically looking at the aggressiveness of the tumor and how likely is that tumor to come back. And if that tumor gets a higher score, meaning it's more aggressive and more likely to come back, well, now there's a benefit to chemotherapy because the more aggressive the tumor, the more aggressive our treatment needs to be in order to decrease the risk of it coming back. Radiation therapy, we touched on that with doing a lumpectomy. So it's required for most patients having a lumpectomy because the risk of that breast cancer coming back, if we were just to remove the breast cancer with a lumpectomy but not follow it with radiation, is much higher. So in order to do a lumpectomy, it's usually required to do radiation therapy so that we don't have a recurrence in that area. There's different protocols to radiation therapy, ranging from 5 treatments to sometimes 4 to 5 weeks. Depends on what the surgery pathology looks like and kind of the protocol that the radiation oncologist believes would be most beneficial in everybody's kind of situation. And then some patients who have had a mastectomy may be required for radiation. So people who have mastectomies don't always need radiation, but there are some people that either they have very large tumors to start with, or maybe one of our margins is too close. We took all the tissue we could, but yet our margin is still too close, may benefit from radiation therapy to try to make sure that, nothing returns. Breast surgery is a big decision, and understanding your options, especially when you've got reconstruction and you've got all the options that we talked about, it's important to understand your options, be comfortable with your breast care team, making sure that you know that you can answer those questions, that those questions are answered to your to your liking. Allow yourself some time to make a final decision. It's hard to make, I know breast cancer, obviously there's some urgency to it, but even if you're allowed a couple of days just to wrap your mind around everything that you learned from your care team, just to give you some time to make that final decision. A lot of times we recommend bringing someone with you when you're sitting in front of in front of the providers and there's so much information being thrown at you. It's hard to hear everything. So bringing someone else who can take notes or just be that second set of ears can be extremely helpful. Making sure you have a list of questions. And I know there's some resources like breastcancer.org and different resources like that actually have come up with a list of questions so that people don't have to think of these questions on their own. You can just print them out from some of these these breast cancer organizations so that you feel like you answered or you asked the right questions and you got those answered. And then lastly, don't be afraid to ask for help. Sometimes it's hard to put yourself first when you're going through something, but it's important in order to be able to recover and just get through everything you're going through. So thank you. I appreciate your time and your listening. And, again, it's great to be here. So thank you for allowing me to do that.
Thank you so much, Amber. Great presentation. We do have a few questions, so I
Sure.
will ask those for you. First question, or it's a statement and a question. I had my first mammogram and had to do a second set of images because they saw something and I have dense breast. Went back in for a few more images from different angles and they determined it was benign without an ultrasound, but recommended an ultrasound next year. How were they able to say benign without the ultrasound? Also, why would they recommend the ultrasound moving forward, but not this time?
Yeah, that's a good question. So when we're doing a screening mammogram, it is solely 2 views. So you kind of get squeezed from top to bottom, and then so they're taking pictures looking top to bottom and then left to right. So it's very few views just to see if they see anything new that doesn't match up to maybe your previous mammogram. When they go in and do the diagnostic mammograms, they're doing more views. It's not just the up and down and the sideways. They can go at different angles. They can magnify that breast tissue to see if there's actually something there. Because sometimes when we just do those two angles, we see something that doesn't look right, but then when we magnify it, there's really nothing there anymore. So sometimes that can be the case where they don't need the ultrasound because they truly can't find anything even wrong on your magnification views. Um, in that sense, I do encourage you make sure that you're talking to your provider and making sure that that is in the case for you, right? Like I can only speculate, this does happen, but I want to make sure that your provider who's reading your reports agrees that yes, the magnification views just they realized there was nothing truly there after once they did some more imaging. Now, as far as the ultrasound that they recommend for next year, what I think that is that because you have dense breast tissue, they are going to supplement your mammogram with an ultrasound. And we can do an automated breast ultrasound where they actually have this handheld thing that they just kind of put over your breast and it takes multiple ultrasound pictures. Sometimes they'll do it freehand. There'll be a tech that just takes the ultrasound probe and goes over every part of your breast, looking for anything in addition to what they've looked at with the mammogram. So I think that that ultrasound that they're recommending next year is actually for screening. It's to supplement your mammogram because you have dense breast tissue. Unfortunately, when we have dense breast tissue, there's a little bit of limitation to the mammogram. The mammogram is still gold standard. I will never, ever, I will always encourage my patients because they're like, I don't want to do the mammogram. It hurts and it's an x ray and I don't like the radiation and all of that. But mammograms are gold standard. They find breast cancers day in and day out. So the ultrasound will just be used to supplement because of your dense breast tissue.
All right, thank you. The next question is, how does breast reconstruction impact a patient's overall quality of life and well-being?
So I I always have to lean towards the answer of um, it is very much a personal decision whether or not you decide to go through breast reconstruction. We absolutely have women that are required to have a mastectomy for whatever reason. Um, and they decide not to go through reconstruction. Had multiple patients because, maybe their priority is they want the least amount of surgery that they have to have and just be done and they're okay with the special surgical bras and prosthetics and all of that. I literally had someone who was a horse enthusiast and still rides horses and she's got to wear that hard vest, gets thrown off the horse all the time. I can't imagine. But she was more concerned that if she puts an implant or reconstruction in there, then she'd have to worry about implant ruptures and all of that. So like for those patients, like their priority is different. Breast reconstruction is wonderful. It can absolutely have a positive impact on patients and their overall well being and how they feel about themselves. As women, our breasts are part of our identity. And if we have to lose that, then, we mourn and it's hard. It's hard to lose something like that. Whether you have to or not, it doesn't make it any easier. So I think breast reconstruction absolutely, if that is what that person needs to feel whole and feel like they can move on from this awful, situation and diagnosis, then it is very important. So I think making sure that you get to talk to a plastic surgeon to discuss all the options and deciding what is right for me and ultimately what do I want in the end of all of this to help me get through.
Thank you. The next question. How do you determine which type of reconstruction method is best suited for a particular patient?
Very good question. And I would definitely have to lean on the expertise of like a plastic surgeon, because they're the ones that are going in, they're the ones that have done the reconstruction on multiple people. So we look at the size of the breast initially, like how small is somebody, and what kind of reconstruction would look good or benefit them. Um, we have to look at like the shape of our breasts. And when it comes to autologous, you know, definitely looking at having a history of smoking is um, very detrimental to our reconstruction options, because smoking hurts our blood vessels. And when we're taking tissue to transplant it into our mastectomy site, those tiny little blood vessels are imperative in order for that tissue to survive and us to have a good reconstruction without wound healing and tissue dying and such. So looking at smoking history and comorbidities. I mean, how much, as far as like, do people have high blood pressure, diabetes, like all of this stuff plays a role into choosing the right breast reconstruction, making sure it's as successful as possible, but also is ultimately giving you what you need in the end.
Thank you. And I have I guess a follow-up question for that with the smoking, because I know I come from a time where when people think of smoking, they think of cigarettes. So
Yeah.
is that just cigarettes, or does that include things like vaping?
It absolutely includes things like vaping. Anything with nicotine will harden our blood vessels. They constrict our blood vessels. And what that does is that decreases our blood flow to certain areas of our body. And we need all the blood flow we can get when we're transplanting tissue from one area to the next.
All right, thank you. The next question. How do healthcare providers help patients cope with potential body image changes following surgery?
So we have, options such as like we have our social workers, which will help. We have a wonderful cancer resource center over here at Rush Copley. It's our Waterford Cancer Resource Center. And most organizations, you're going to find something similar. And if they don't have something that is within their organization, they're going to have some sort of a resource or a referral base to send you. But for instance, our Waterford Cancer Resource Center, they have support groups for women who have gone through a breast cancer diagnosis and, just need that community support and that, other people that understand what they have gone through, to kind of build them up and help them get through that journey. So I would say definitely asking your providers, like what kind of community resources do you have available for me in regards to support and healing, right? There are other resources online. I mean, when you go to like breastcancer.org or NCCN, um, I think it's .com. I'm blanking at the moment. But breast cancer websites, they also have their own resources um, to help with that. But there's multiple out there, and I definitely encourage my patients to at least check them out and consider them because it's important for the healing process.
Yeah, thank you. We also, on our website, we have a breast cancer resource guide. So that is also an option for people looking for somewhere to start.
Wonderful.
Um, Another question is, how does insurance coverage impact a patient's options for breast reconstruction?
So most reconstruction is going to be covered by insurance. We've done a very good job of pushing through like the political channels and legislation and stuff, saying that this is reconstruction is not it is part of the breast cancer treatment. It's not separate. It's not, basically optional. Like this is what needs to happen in order to treat breast cancer. And I think, that's kind of it's basically been, it's well known now. Insurances do not push back for the most part on breast reconstruction, even the autologous, even like the more complex and stuff like that. If the plastic surgeon says this is what the patient wants, this is what we're doing, there's not a lot of pushback from insurance anymore.
That is good to know.
Yes,
Okay.
yes. I mean, there's always going to be those, couple of cases that just don't make sense and we have to fight, but that is not the norm.
Good. Okay, well, thank you so much for a great presentation. That was all the questions we had. We appreciate you doing this with us. Hopefully we can do it again. Some type of presentation from you. We really appreciate it. Thank you so much for your time. And if anyone has any follow-up questions, you can email them to us, and we will help you get those answered. Thank you,
Thank you so
everyone.
much.
You're welcome.